Picture the drive home after a truly devastating case.
Yeah.
The physical operation has ended, the patient is in recovery, or, perhaps they have been transferred to the intensive care unit.
Right.
The difficult conversation with the family in that sterile, quiet little room is over. The clinical notes are typed, signed, and the chart is definitively closed.
The physical work is done.
Exactly. You walk out of the hospital doors, the cold air hits you, you get into your car, and you shut the door.
And that sudden silence is just deafening.
It really is. In that heavy silence as you pull out of the car park and onto the dark roads, the physical operation is over. But the psychological operation is just beginning. You are sitting there, gripping the steering wheel, and the catastrophic moment starts playing on an endless, involuntary loop in your mind.
That is precisely the moment the absolute isolation sets in.
Yeah.
You are completely alone with the sheer weight of an irreversible outcome.
Because the rest of the world is just going about its evening.
Exactly, yes. The rest of the world is entirely normal, but you are trapped entirely in the past few hours. The silence in the car during that drive is filled with the visceral realization that something has gone terribly wrong on your watch, under your hands.
And that is exactly what we are dissecting today on this deep dive. Welcome, everyone. We are looking directly at what happens inside you, the surgeon, when things go wrong.
Whether that outcome was due to a completely unpredictable anatomical anomaly, an equipment failure, or a genuine technical error on your part.
Right. Because surgery is a profound anomaly in the modern working world. I mean, we are not moving numbers on a spreadsheet or making abstract corporate policy.
Not at all.
We are an incredibly unique profession where individuals make immediate, physically irreversible decisions with their hands on a daily basis.
Yes, and in orthopedics particularly, you are using sheer physical force.
Drills, saws, mallets.
Spot on. So when a complication arises, the burden of that physical action is absolute. It is intimately tied to your own physical movement. It is entirely visceral.
And that burden has a formal clinical framework, doesn't it? Even though, honestly, it is practically non-existent in the curriculum of medical schools.
Or even during specialist registrar training, yes. The clinical term for this is the second victim phenomenon.
The second victim phenomenon. Let's unpack that for a second.
Well, it is the formally recognized reality that a clinician is inherently harmed by participating in a patient's harm.
Right.
The patient, unquestionably, is the first victim of the adverse event. But the surgeon, the anesthetist, the scrub nurse, the entire theater team, really they become the second victims.
Because the trauma of having caused it inflicts an injury on them too.
Precisely. The psychological trauma of having caused or even simply having been present for a severe complication inflicts a distinct, measurable neurobiological and emotional injury on the practitioner.
Which introduces a glaring contradiction in the way we prepare you, the surgeons, for the reality of your jobs.
Yeah.
I mean, think about the modern surgical training program.
It is entirely focused on the mechanics.
Yes, we mandate incredibly rigorous, structured protocols. You have the multi-step WHO surgical safety checklist.
Before you even ask for the scalpel, you are confirming the patient, the site, the procedure.
The anticipated blood loss, the equipment. We prepare meticulously, almost obsessively, for the physical act of surgery. Yet, we provide zero protocol, zero structured preparation, and absolutely no checklist for that emotional drive home.
Nothing at all.
You are trained for over a decade on exactly how to manage a catastrophic intraoperative hemorrhage, step by step. But you are given absolutely no framework for how to manage the catastrophic internal monologue that follows it.
It is a profound, systemic, structural failure in our educational model. We spend millions of pounds and thousands of hours equipping you with the technical armamentarium to reconstruct incredibly complex anatomy.
But we leave you defenseless.
Completely defenseless against your own cognitive aftermath. You step out of theater, and you are essentially dropped off a cliff.
And because there is no protocol in place, the psychological sequelae do not just magically disappear, do they?
No, they manifest in highly predictable and very often deeply destructive ways. When we look at the internal cascade that follows an adverse event, we have to understand something fundamental.
Which is?
We are not looking at a collection of random emotional frailties. We are observing a deeply ingrained neurobiological reaction to acute stress and moral injury.
Okay, then let's break down exactly what that internal cascade looks like. If we are finally acknowledging this massive void in our training, we have to map out the exact clinical symptoms that rush in to fill it.
Yes.
What actually happens to your cognitive state after that drive home? I mean, the most immediate and frankly the most punishing symptom seems to be rumination.
Oh, absolutely. And to be clear, this isn't simply reflecting on a case for continuous improvement.
Right. It's not a calm, objective review of your technique.
Not at all.
But
This is the intrusive, entirely involuntary replay of the event. It hits you at the most inappropriate times.
you might be sitting at the dinner table with your
Yeah.
family.
Or standing in the shower. Or, and this is where it gets incredibly dangerous, you are scrubbing in for a completely unrelated case the next morning.
Oh, wow. And the flashback just hits you.
Yes, suddenly the exact moment the complication occurred flashes vividly across your mind's eye. The tear, the crack, the sudden drop in blood pressure on the monitors.
It's terrifying, but why does the brain do that?
Well, that rumination is actually the brain's maladaptive attempt to solve a problem that is already entirely in the past.
Okay, walk me through the neurobiology of that.
If we look at the neurobiology, your amygdala, which is the brain's primary threat detection center, has registered the adverse surgical event as a massive trauma.
So it sounds an alarm.
It sounds an alarm that will not shut off.
Yeah.
It then signals the hippocampus to keep that specific memory violently active. It is forcing you to review the footage over and over in a desperate, really an impossible search for the exact microsecond where you could have altered the outcome.
Wait, let's pause on that idea for a second. So if I'm driving home or standing in my kitchen and that flashback hits me, my brain is quite literally reacting as if the trauma is happening right now.
Exactly. It is an evolutionary survival mechanism that is misfiring. In a primal sense, the brain believes that if it reviews a threat enough times, it can somehow prevent it from having happened.
Or at least guarantee it never happens again.
Right. So it floods your system with cortisol and adrenaline.
Yeah.
Your heart rate variability changes. Your breathing becomes shallow.
But in the modern surgical context, there is no physical threat to run from.
Precisely. The threat is a completed surgical outcome. So this mechanism simply locks you into a relentless cycle of intrusive, exhausting flashbacks. Your nervous system is redlining while you're just trying to eat breakfast.
And those flashbacks inevitably breed the second symptom in the cascade, which is profound, crippling self-doubt. It is this insidious questioning of your fundamental competence as a clinician. But, I have to challenge this slightly. Surely a veteran consultant has the ego and the sheer volume of data to brush that off.
You would think so, wouldn't you?
Logically, 10,000 successful joint replacements should easily outweigh one bad outcome. Why doesn't the rational brain just win that argument?
Because the rational brain goes offline.
Wait, really? A senior surgeon with 20 years of proven technical excellence just loses access to that logic.
Yes, they allow one anomalous complication to suddenly invalidate their entire career in their own mind. And the answer lies in how surgeons inherently construct their professional identity.
Explain that.
From the moment you enter medical school, you are operating in an environment that demands absolute perfection. Over time, your ego, your self-worth, and your clinical identity become inextricably enmeshed with your surgical outcomes.
So you are not just a person who does surgery.
Exactly. You are a surgeon. It's your entire identity. So when an outcome fails, you feel that you have fundamentally failed as a human being.
Oh.
We fall prey to what psychologists term the negativity bias. But in surgery, it is amplified to a terrifying degree.
Meaning we are wired to remember the bad more than the good.
Precisely. The human brain naturally weighs negative experiences much more heavily than positive ones. Again, it's a survival tactic.
Right.
But when you add the immense moral responsibility of patient safety, that one adverse event becomes a cognitive superstimulus. It completely overwrites the thousands of successful data points in your career history.
So you don't rationally forget your past successes.
No, you don't forget them intellectually.
Yeah.
Rather, the emotional valence of that single failure is so high that it renders all of your past successes psychologically inaccessible in the acute phase.
You literally cannot access the feeling of being a good surgeon.
That's it, exactly. It is not an intellectual failing. It is a neurobiological hijacking.
A neurobiological hijacking. That perfectly captures the visceral reality of it. You are held hostage by the one complication.
You truly are.
And when you are held hostage like that, it leads directly into the third manifestation in this internal cascade, which is the pendulum swing between hypervigilance and avoidance.
Yes, the two extremes.
It manifests as two very distinct behaviors, right? On one end of the spectrum, you have overchecking routine steps to the point of clinical anxiety.
Overchecking everything.
You find yourself obsessively confirming the angle of a guide wire or checking a perfectly sound anastomosis 4, 5, 6 times. You delay the procedure, you annoy the theater staff, and you second-guess your own hands.
And on the other extreme,
On the other extreme, you actively avoid similar cases. You triage them away to the junior team, or you invent entirely plausible reasons why another colleague might be better suited.
simply to avoid the traumatic trigger of that specific anatomy.
Exactly. So what is happening there biologically?
Well, both of those extremes are classic textbook trauma responses. They are the fight or flight mechanism playing out directly in the operating theater.
Hypervigilance being the fight response.
Yes. Hypervigilance is the physiological state of remaining permanently in fight. As I mentioned, your baseline cortisol levels remain elevated. You are anticipating disaster at every single anatomical corner.
Which must be profoundly exhausting.
It is. And ironically, it degrades your operative fluidity. A great surgeon operates with a degree of flow and subconscious competence. Hypervigilance shatters that flow, which actually degrades your decision-making capacity.
And avoidance, conversely, is the flight response.
Precisely. By refusing to engage with similar cases or even refusing to have conversations about the complication, you are trying to starve the trauma of oxygen.
But that doesn't actually work, does it? I mean, avoiding the procedure doesn't cure the fear of it.
It does the exact opposite. By avoiding it, you are actively cementing the fear. You are teaching your own nervous system that this specific procedure is fundamentally dangerous to your survival.
Wow.
It guarantees that the anxiety will be exponentially worse when you are on call and inevitably forced to perform it again. You are shrinking your own clinical comfort zone until you are trapped in a very narrow bandwidth of practice.
Which brings us to the final aspect of this cascade, unprocessed grief.
Yes,
We rarely use that word in medicine unless we are talking about a patient's family, but there is a reality of genuine mourning for patient harm.
there absolutely is.
If a patient is severely disabled, if they lose a limb, or if they die as a result of a surgical complication, the surgeon experiences a profound sense of loss and culpability.
And yet, our surgical culture provides absolutely no socially acceptable outlet for this grief.
None at all. You cannot weep in the staff room. You certainly cannot express emotional devastation in the morbidly clinical adversarial environment of a morbidity and mortality meeting.
So the grief simply accumulates. It calcifies into a permanent heavy weight that you carry in your chest.
This is why it is so critical to reframe these reactions. I mean, if you are listening to this right now and recognizing these symptoms in yourself, you must understand that these are not emotional frailties.
They are not indicators that you lack resilience.
Or that you are somehow unsuitable for the rigors of orthopedics.
No, they are highly predictable, deeply human, neurobiological responses to immense cognitive and emotional loads.
Right, because if you place any human brain under the exact parameters of high-stakes, irreversible decision-making, and then introduce a catastrophic failure.
This internal cascade is the physiological certainty. Recognizing that it is biology, not weakness, is the very first step toward dismantling the shame associated with it.
But the shame is entirely endemic to our profession, isn't it? Because these psychological sequelae, the rumination, the doubt, the grief are so intensely uncomfortable, we instinctively deploy survival tactics to bypass the pain.
We look for a way out.
Exactly. When your brain is trapped in that state of hypervigilance, human nature dictates that we look for an escape hatch. And in surgery, those escape hatches are often culturally ingrained and highly destructive.
They are maladaptive mechanics.
Yes, the maladaptive mechanics, the coping strategies we employ that ultimately fail us. The most prevalent of these, really the absolute bedrock of historical surgical culture, is the stoic posture.
A stiff upper lip.
The act of simply pretending it didn't happen. We don the heavy armor, we walk into the next theater list, we scrub up, and we project absolute unflappability.
We operate under the illusion that ignoring the rumination somehow neutralizes it.
Exactly. But it doesn't, does it?
No, the stoic posture is perhaps the most dangerous tradition handed down through generations of surgical training. It goes all the way back to the early pioneers of surgery who modeled absolute emotional detachment as the ultimate clinical ideal.
Right.
It operates on the entirely false premise that suppression equals elimination. But neurobiology, once again, dictates otherwise. When you suppress a traumatic emotional response, it does not dissipate into the ether.
It simply goes underground.
Yes. And when psychological pain goes underground, it begins to manifest somatically.
Physical symptoms.
Absolutely. You see it in chronic fatigue, in severe insomnia, in unexplained physical ailments like migraines or gastrointestinal issues,
Mm.
and in a gradual creeping cynicism.
The stoic posture demands that you systematically sever the connection between your actions and your emotions.
And over years, that severance slowly erodes your capacity for empathy, not just for your patients, but for your own family, your colleagues, and ultimately yourself.
And when that stoicism inevitably cracks, when the sheer force of will fails to keep the nightmares at bay, we see the shift into much darker territories.
Yes, we do.
Substance misuse is the quiet, deeply uncomfortable truth of our profession. It is the generous pour of whiskey when you finally get home.
Not to celebrate a good day.
No, to chemically blunt the sharp edges of a disastrous one. It is using alcohol as a crude, unprescribed anesthetic for the aftermath.
We rarely discuss this openly.
We don't. But the reliance on alcohol to simply force the brain to shut down so you can get 3 hours of sleep before the next day's theater list is a silent epidemic within our ranks.
It is a highly predictable form of self-medication. Alcohol is a central nervous system depressant. It temporarily dampens that hyperactive amygdala response we discussed earlier.
So it provides a fleeting, short-term relief from the rumination.
Yes, but the physiological rebound is brutal. Let's look at sleep architecture for a moment. As the alcohol metabolizes in your system during the night, it severely disrupts your sleep cycles, specifically REM sleep.
And REM sleep is crucial, isn't it?
It is precisely the phase when the brain processes, contextualizes, and integrates emotional memory. So by drinking to forget the complication, you are biologically preventing your brain from ever actually processing it.
Wait, so the very thing you are using to sleep is actually trapping the trauma in your brain permanently?
Exactly. You wake up exhausted, the trauma remains completely unresolved, and the cycle perpetuates the next night. It is a short-term anesthetic that functions as a long-term poison.
You are chemically ensuring that the second victim phenomenon lasts for years rather than weeks.
Yes.
It is staggering when you look at the hypocrisy of our surgical culture in this context. We exist in a paradigm that demands rigorous, peer-reviewed, evidence-based medicine for absolutely every aspect of patient care.
Everything must be evidenced.
Right. We wouldn't dare change a postoperative antibiotic protocol or a deep vein thrombosis prophylaxis without a massive multi-center meta-analysis.
Oh, we wouldn't.
Yet when it comes to the psychological survival of the highly trained practitioners delivering that care, we historically turn a completely blind eye. We rely on entirely unevidenced, demonstrably destructive coping mechanisms.
We accept silent suffering and substance reliance as part of the necessary character building of a surgeon.
That hypocrisy is the very engine of the burnout crisis we are seeing globally. And it doesn't just harm the surgeon, it manifests clinically in ways that directly harm future patients.
This is a crucial point.
Consider the coping mechanism of misdirected blame versus overcorrection. When an adverse event occurs, some surgeons instinctively externalize the blame to protect their fragile ego.
It was the scrub nurse who handed the wrong instrument.
The anesthetist was too slow to react. The hospital equipment was faulty.
This ego protection mechanism completely prevents the internal processing and the clinical learning required for healing. You learn nothing if it is never your fault.
But the opposite extreme, as we touched on earlier, is equally pernicious. Permanent hypervigilance.
Yes. Let's make that concrete.
Yeah.
Because permanent overcorrection is something I've seen happen, and it is tragic.
Absolutely. Let's say a senior consultant experiences a rare complication, a significant nerve injury during a routine exposure, perhaps a total hip arthroplasty where the sciatic nerve is compromised. For the rest of their career, they are permanently hypervigilant about that specific step. They dissect so slowly, so tentatively, that their operative times literally double.
Precisely. And we have to ask, what happens when operative times double for every single patient from that day forward?
Infection rates rise significantly.
Exactly.
Yeah.
Tourniquet times exceed safe physiological limits, blood loss increases, overall patient morbidity increases.
The surgeon alters their technique to protect themselves from the specific emotional trauma of that past complication.
But in doing so, they introduce new, unrecognized clinical risks to every single future patient they touch. Permanent hypervigilance is a trauma response masquerading as meticulous surgical care.
It is defensive surgery.
And it is inherently dangerous. You are operating on the ghost of the past patient, not the anatomy of the current one.
That is a chilling way to put it, operating on the ghost of the past patient. And when that defensive posture becomes too exhausting to maintain day in and day out, we see the final maladaptive strategy.
Impulse quitting.
Yes, making sweeping, dramatic career decisions in the acute phase of trauma. A consultant has a devastating outcome in a complex revision, and within a week, they declare to their clinical director that they are never doing revisions again.
Or worse, they decide to leave the subspecialty entirely.
Or step away from clinical medicine altogether to do medical legal work. They walk away when the pain is at its absolute peak.
This is a profound tragedy of lost potential. Big life decisions made in the immediate, acute aftermath of a traumatic event are almost universally the wrong decisions.
Why is that?
Because the cognitive framework in that moment is entirely governed by the biological desire to escape pain. They are not making a rational career choice. They are fleeing a burning building.
Right.
What they actually need is structural processing and time to let the nervous system reset. We lose highly capable, deeply experienced, technically brilliant surgeons to these impulse decisions simply because the culture offered them no alternative pathway through the darkness.
So, if the traditional route stoicism, self-medication, blame, overcorrection, and escape all ultimately fail us, we have to pivot. What is the alternative pathway?
We have to look at what actually works.
If you are a mid-senior surgeon listening to this right now, and you are carrying the weight of a recent or perhaps a long-past calcified adverse event, what protocol should you adopt tomorrow morning?
Let's look at the frameworks grounded in evidence-based recovery.
And the cornerstone of this recovery, without question, is targeted peer support.
Targeted peer support is absolutely non-negotiable for recovery. And the parameters of this support are highly specific.
How so?
It requires finding one trusted peer, not a generic hospital counselor, not a sympathetic administrator, not even a spouse. It must be specifically a fellow surgeon who has experienced surgical complications themselves.
The shared clinical context is the active therapeutic ingredient here.
It is.
Because they understand the visceral reality of it. You don't have to explain the anatomy. They understand what it feels like physically to hold the instrument when the vessel tears or when the bone fractures under the mallet.
Exactly. When you attempt to describe an adverse event to someone who lacks that specific clinical context, you have to spend all of your cognitive energy translating the medical reality for them.
You are explaining what a pedicle screw is.
Or what a dural tear looks like.
Hmm.
And that translation process intellectualizes the event, which distances you from processing the raw emotional reality.
I see.
When you speak to a fellow surgeon, that translation is entirely unnecessary. You just say the name of the procedure and the complication, and they instantly know the horror.
This is much faster.
The conversation does not require length. You don't need a 2-hour session. It does not require a deep psychological unearthing of your childhood. It often just requires the profound, immediate validation of shared clinical weight. Hearing a respected peer look you in the eye and say, "I have been exactly where you are, it is utterly devastating, and you are not a bad surgeon," acts as an immediate countermeasure to that crushing self-doubt we discussed earlier.
It normalizes the trauma.
It pulls you out of the isolation of your own mind.
But inevitably, when we talk about peer support, surgeons immediately point to the M&M, the Morbidity and Mortality Conference.
Yes, they do.
They say, well, we discussed the case at the departmental M&M on Friday. I presented the slides. That was my peer support. We need to be incredibly clear here about the boundaries of the M&M.
We do.
Engaging with M&M is undeniably vital for clinical learning, for governance, and for systemic improvement.
Yeah.
But we must strictly recognize that it is utterly ill-equipped for emotional processing.
It is a critical, fundamental distinction. The M&M is a clinical autopsy. Its sole purpose is to dissect the mechanics of what went wrong, to identify systemic hospital failures, anatomical variations, or technical errors to prevent future occurrence. It is an intellectual, heavily scrutinized, and often adversarial environment.
You are standing at a podium defending your actions.
Exactly. What the individual surgeon requires after an adverse event is a psychological autopsy. The M&M asks, what happened to the patient? The necessary peer support asks, what is happening to you?
I love that framing. Using the M&M as your only outlet for processing is like trying to fix a complex software glitch with a massive physical spanner. It's the wrong tool entirely.
It leaves the emotional work entirely undone. And worse, it often adds dense layers of defensive anxiety due to the public scrutiny of the conference.
Yeah.
You leave the M&M feeling professionally bruised, not psychologically healed.
Which is exactly why normalizing professional intervention is the next logical step in an evidence-based recovery framework. We are finally, slowly, seeing a fading stigma around the use of clinical psychologists, therapists, or specialized coaches who focus specifically on physician care.
And it's about time.
Historically, seeking psychological help was viewed as a career death sentence. It was a sign of inherent weakness that you whispered about. But the data now clearly shows that surgeons who engage professional support recover with much cleaner, faster trajectories.
They recover cleanly because a trained professional provides a structured, objective environment to process the trauma without the heavy baggage of departmental politics, career competition, or personal ego.
What kind of modalities are they using?
Therapeutic modalities like cognitive behavioral therapy or EMDR, eye movement desensitization and reprocessing, can actively rewire the maladaptive rumination loops in the amygdala.
So it's very clinical.
Yes, you must begin treating professional psychological support precisely as you would treat any other clinical resource. If you developed a severe tremor in your dominant hand, you wouldn't hide it with stoicism.
No, you would seek a neurologist immediately.
A psychological injury from a catastrophic clinical outcome is no different. It is an occupational injury, and it requires specialist intervention to ensure you remain fit for practice.
Now, I want to drill down into how we integrate this recovery into our personal lives, because there is a very fine, incredibly difficult line to tread here regarding domestic boundary setting.
Yes, coming home is often the hardest part.
How do you disclose the reality of your horrific day to a non-clinical partner when you finally walk through the front door? Let's look at a strategy of bounded disclosure.
Keeping the clinical details entirely out, but explicitly acknowledging the emotional weight.
For instance, using phrases like, "I had a remarkably hard day today. I cannot share the clinical details, but I need you to know it was hard and I am struggling."
Right.
How does a surgeon successfully walk that tightrope? Because the risk here seems twofold. Either you say nothing, you pour a drink, and you isolate yourself, creating a massive chasm in your marriage.
Or you overshare.
Exactly. Seeking comfort, you accidentally transfer the graphic trauma of a surgical disaster onto a spouse who entirely lacks the clinical context to process it.
Walking that tightrope requires deliberate, premeditated communication strategies. It cannot be done on the fly when you are exhausted.
No.
If you bring the full, unvarnished horror of a surgical complication home, the sights, the sounds, the literal blood, the smell of the diathermy, you inflict severe vicarious trauma on your partner.
Because they don't have the training to compartmentalize it.
Precisely. They do not possess the clinical compartmentalization skills that you spent a decade in medical school and residency developing. They will carry that imagery, and it will harm them.
But the stoic silence harms them too.
Conversely, yes, the stoic silence, the "I'm fine" approach, breeds immense resentment and alienation. Your partner knows something is wrong, but they are shut out.
So bounded disclosure is the middle ground.
Yes. The strategy of bounded disclosure, stating explicitly that the day was hard without detailing the clinical mechanics, serves a very specific psychological function.
What does it do?
It allows you to signal your emotional state to your partner, providing them with a logical explanation for your withdrawal, your profound fatigue, or your distraction at the dinner table.
Right.
It keeps the relationship open and honest. It invites their support for your emotional state, perhaps just sitting with you or taking over the evening chores.
Whilst keeping the clinical burden squarely where it belongs, with you and your professional peers.
Exactly.
It is about giving your partner the context for your behavior without giving them the graphic content of your trauma. And threading through all of these interventions, the targeted peer support, the professional therapy, the domestic boundaries, is the active role of time.
Time is a massive factor.
We frequently hear the well-worn platitude that time heals all wounds. But in this context, time only heals if the processing isn't actively suppressed.
Time is merely a neutral vector. It is an empty vessel.
Okay, explain that.
If you employ the maladaptive strategies we discussed earlier, the substance misuse, the absolute avoidance, the stoic suppression time will simply allow the trauma to fester, calcify, and turn into chronic bitterness.
It compounds the moral injury.
It does. However, if you actively engage in the evidence-based frameworks, acknowledging the pain, speaking truthfully with peers, setting healthy boundaries, then time allows for the consolidation of the memory.
So the sting fades.
The acute visceral sting softens. The complication gradually transitions from an active, threatening trauma into a deeply embedded clinical lesson. Time helps the surgeons who grant themselves the grace to actually feel the impact. It destroys the ones who refuse to.
But doing all of this requires a supportive environment, doesn't it?
Absolutely.
This brings us to a critical shift in our focus today. Because while individual recovery protocols are essential, you do not execute them in a vacuum. You operate within a wider ecosystem, a hospital trust, a specific department. We have to elevate this discussion from the heavy burden carried by the individual surgeon to the systemic responsibility held by clinical directors, medical directors, and program leads. We are looking at the cultural imperative for surgical leadership.
We cannot put the entire burden of recovery on the traumatized individual. The structural environment of a department dictates the survival rate of its surgeons following adverse events.
Leadership creates the weather.
They absolutely do. We are fundamentally looking at the dichotomy between a blame culture and a learning culture.
Okay, define a blame culture for us.
In a blame culture, the immediate knee-jerk reaction to a complication is punitive. The focus is entirely on finding the culprit, isolating them, and protecting the institution from litigation.
Which just breeds hidden suffering.
Exactly. Surgeons learn to obfuscate,
Yeah.
to minimize complications in their notes, and they eventually retreat into quiet attrition.
And that quiet attrition is exactly what destroys a department from the inside out, isn't it? It isn't always a dramatic resignation. It is the senior consultant who simply stops taking complex cases, referring them all to a tertiary center.
Or the promising registrar who decides to switch to a less acute specialty because they see how the consultants are treated when things go wrong.
A learning culture, by contrast, operates on a completely different premise. It provides structural, highly visible support right alongside the necessary clinical review.
Yes, it treats the second victim phenomenon as a systemic inevitability of surgical practice that requires active management, not a personal failing that requires punishment.
And this is exactly where we must dismantle a pervasive, deeply destructive false premise in surgical leadership.
The idea that empathy makes us weak.
Yes, it is the deeply held, often unspoken belief that empathy somehow erodes clinical standards. There is a tangible fear among old guard leadership that if we are too soft on surgeons after a complication, if we offer them therapy instead of a reprimand, we will lower the bar for clinical excellence and patient safety will ultimately suffer.
Which is demonstrably empirically false. Empathy and high clinical standards are not mutually exclusive. In fact, they are synergistic.
Let me make sure I am clarifying this for everyone listening. The central thesis here is that accountability and care must absolutely coexist.
They must.
You can rigorously investigate an adverse event. You can demand a thorough root cause analysis. You can hold a surgeon entirely accountable for a technical error or lapse in judgment. And in the very same breath, you can ensure they have the psychological support required to survive that accountability and learn from it.
That is the exact architecture of a healthy, high-performing department. Leadership sets this tone through explicit structural components.
Like what?
When an adverse event occurs, a healthy department does not wait for the surgeon to break down or start drinking before offering help. They proactively deploy a peer support protocol.
So the leadership initiates it.
Yes, the clinical director checks in not just regarding the M&M presentation slides, but regarding the surgeon's actual well-being.
That visibility is key.
If leadership visibly models the healthy processing of adverse events, if a senior, highly respected consultant stands up in an M&M and says, "I had a very similar complication 5 years ago. It devastated me. I sought help, and here is how I recovered," then the trainees and junior consultants will immediately follow suit.
The cultural DNA of the entire department changes in that single moment.
Exactly.
We simply cannot afford to ignore this any longer. This is not merely a well-being issue, a soft topic to be relegated to a mandatory click-through online module or an optional Friday afternoon seminar.
No, it is critical.
This is a critical workforce retention crisis. Departments are hemorrhaging highly trained, incredibly valuable specialists to preventable burnout stemming from a single poorly managed complication. Think about the economics of it.
It's staggering.
We invest millions of pounds and decades of intense training to produce a single senior orthopedic consultant. To lose them because we fail to support them through the absolute inevitable reality of surgical risk is a catastrophic systemic failure.
It is an entirely unsustainable model. The complexity of surgery is only increasing. The acuity and comorbidities of our patients are rising.
Complications will happen.
They are a statistical certainty of the job. The departments that will thrive in the next decade will be the ones that recognize the second victim phenomenon as a core operational risk and actively mitigate it through structural care and unyielding peer support.
Which brings our focus back to where we started today, back to that silent, solitary drive home in the dark after the chart closes.
The drive we all know too well.
The profound truth is Every single surgeon listening to this will carry hard cases for the rest of their career. You all have ghosts.
We all do.
The weight of those adverse outcomes is permanent, and carrying it is an inherent, inescapable part of the surgical profession. The objective of this deep dive, the objective of implementing these frameworks, is not to eliminate the weight. That is impossible.
It is.
The goal is to learn how to carry it in a way that preserves your humanity, maintains your clinical efficacy for the next patient, and protects your personal relationships.
You cannot change the past outcome. The clinical reality is written. But you have absolute agency over how that outcome shapes your future practice.
By actively rejecting the toxic stoicism.
Yes, by refusing to isolate yourself in that car, and by actively seeking out the peers who understand the specific burden you carry, you transform a potentially career-ending trauma into a profound source of clinical wisdom and empathy.
And so I want to leave you with a challenging paradigm shift to mull over as you head into your next shift. As you progress in your career and take on leadership roles, the ultimate legacy of a senior surgeon is not merely your low complication rate or the sheer complexity of the procedures you mastered.
Your ultimate legacy is whether you actively refuse to pass down the toxic, silent coping mechanisms to the next generation of trainees.
When a junior colleague experiences their first truly devastating outcome under your watch, what will you do? Can you be the peer someone else calls on their drive home?
That is the very definition of true clinical leadership, breaking the cycle of silence once and for all.
If you found value in this deep dive, please take a moment to rate the show and share it with a colleague who might need to hear it today. We owe each other this conversation, especially when it is profoundly uncomfortable. Until next time, take care of yourselves and take care of each other.